for those of you who I haven't met, my name is Melanie Liu, and I am one of the faculty in the Cardiothoracic Anesthesia Division here at the University of Washington Medical Center. And I just want to thank Dr. Nikravan and Dr. Ojo for the opportunity to present this lecture on ultrasound for vascular access. So hopefully you guys can all see my screen. And sorry, I just got a message about a case, OR12. Okay, so I am going to be talking for ultrasound for vascular access today. And first, I just wanted to go over my learning objectives. So today we are going to talk about using the benefit of using real-time 2D ultrasound guidance for vascular access. We're going to describe how to optimize your 2D vascular ultrasound imaging, and we're going to discuss some techniques for real-time 2D ultrasound guidance in venous and arterial cannulation. I do want to start off with a quick poll because I kind of want to understand how much am I actually preaching to the choir here. So this is just a quick poll on how kind of your practices in terms of what you use ultrasound for. So hopefully this works. And there's going to be 3 different questions. And so the first question here is going to be, how often do you use ultrasound for internal jugular venous cannulation? The second one is, how often do you use ultrasound for subclavian vein cannulation? And third is, how often do you use ultrasound for arterial cannulation? And I'll give you guys a minute to go ahead and do that. Okay, so just trying to get some results here. Yeah, just give this 10 more seconds to give people a chance, the newly joined, to answer these. Okay, last chance, going, gone. So let's see, if I end poll, hopefully I can share the results. And it looks like, hopefully you guys can all see that. So it looks like 64% of you always use ultrasound for IJ cannulation. With subclavian vein cannulation, a little bit less, 48%, as is the most that we got, which is sometimes. Only 20% use it always. And then for arterial cannulation, it's a little bit more varied. So 12% always use it, and then the rest are kind of somewhere between sometimes and never. And I will say at the University of Washington, I think, as you can probably imagine, between Dr. Nikravan and our other faculty, we are a pretty ultrasound heavy institution, ultrasound friendly institution. And most of our residents actually will learn how to use ultrasound for venous and both venous and arterial cannulation very, very early on, and they are very facile with it. So I'll show you some of the techniques that I've seen here and have actually incorporated into my practice since I came here. Okay, so first of all, why use ultrasound? Why are we talking about this? So ultrasound, dynamic real-time ultrasound, which is you're visualizing the vessel as you are cannulating it, is something that we use both for arterial and venous access. And this really helps with pre-procedure planning. So you're scanning the vessel, making sure that's patent, making sure that there's no clots or anything that would hinder your access attempt. It gives you guidance for your needle entry, especially if you're visualizing the needle tip, which I'll show in a little bit later. Gives you confirmation of your guide wire location, and it helps you identify any complications such as hematomas or pneumothoraces. And in terms of looking at the vessel itself, I don't routinely do a pre-procedure scanning on both sides of the neck, but I will do this, for example, in patients who I know have had central lines in the past, because I can't even tell you, how many times a pre-procedure scan may have shown me, hey, this vessel is not going to be a good target for cannulation, and then having to re-prep the entire other side of the neck. So can be helpful even before you start needling the patient. And the most important thing for why we use ultrasound is that it's been shown to reduce the incidence of procedural complications. For example, inadvertent puncture of adjacent structures by decreasing the number of unsuccessful attempts. One of the most important things when you are picking up an ultrasound probe for your cannulation attempt is to actually select the correct probe. So in most of these situations, because the vessels that we're looking at are usually pretty superficial, like the IJ or most arteries, a high frequency linear array transducer should be selected in most situations because it will give you the optimal spatial resolution. Now, you can also use a curvilinear probe if you are going to be cannulating deeper structures, for example, femoral vessels in obese patients. And just to show you these pictures, so we have at Montlake, the usual candidates for selection are these three probes. So this one here is your high frequency linear array transducer. You guys are probably all familiar with this. And the frequencies of the emits are between 5 to 10 megahertz. We also have this a small footprint high frequency linear array transducer, and we often refer to this as the hockey stick for I mean, hopefully you guys know what I'm talking about with hockey sticks. But basically, this one is actually even a smaller, array, and gives you even better imaging of superficial vessels. And this emits 10 to 15 megahertz. And then here's a curvilinear probe. Again, most of the time, you're not going to be picking up this probe for your vascular access. It definitely is much lower frequency. It's good at imaging deeper structures, but for your superficial structures like your IJ, if you're using this for radial artery or even for subclavian, this is probably not going to be your probe of choice. And so again, most of the time you're going to be using these. So in terms of vascular modalities, oh, by the way, if you're joining, please go ahead and mute yourself, and then I'm happy to take some questions at the end. So for vascular imaging modalities, usually 2D imaging will be your modality of choice. And then color imaging, you should not be really using this when you're actually doing the cannulation, because this will actually decrease your resolution when you put on the color. But it can be helpful in differentiating between venous and arterial structures. Obviously, venous arterial structures will be pulsatile, right? And in this situation, I wanted to show this picture because obviously this looks like an artery, right? You can see on the 2D it's pulsatile, but what is this thing? Once we throw color on, we realize it's not a vessel, or it's not something that we have to worry about, and certainly not what we want to aim towards. Talking about probe placement, so just a couple of tips for actually how to use a probe. So when you're holding your ultrasound probe, you really want to stabilize yourself as much as possible. So you're gripping the probe right where, basically right at the point where it meets the patient. You are using not just your fingers, and I see this happen a lot with our trainees, right? So they're gripping the probe just with their fingers, and this really doesn't make things very stable, right? Because your fingers kind of twist a lot more than your whole hand. So you're trying to use a palmar grip, and you're trying to stabilize your hand against something, right? So if you're going to be cannulating the IJ, you're often stabilizing against the angle of the jaw or the neck. And this is the position that we often refer to as afternoon tea with the PDL. In terms of probe orientation, so most of our probes will, especially the linear array probe, will give you some indication of which side is which. And so, for example, on the linear array probe, this dot will correspond to the left side of the screen. And you always want to orient your probe with the left side of the probe corresponding to the left side of the image if you're doing out of plane cannulation where you're seeing the vessel in short access. And you want the left side of the image to correspond to the far end of the probe if you're doing in plane cannulation where you're seeing the vessel in long access. And so, for example, if you're doing in plane, then this side should be facing you. And if you're scanning one note here is, again, you always want the left side of your image to correspond to the movement of your needle, right? So if you're scanning the right neck, then you want the left side of your screen to be medial, right? More towards. And then if you're scanning the left neck, then you want the left side of the screen to be lateral. So again, kind of mimicking which way your needle is going to be moving. I'm trying to advance my slide here. So in terms of image optimization, a couple of things that we want to do. So we always want to adjust our laterality and image depth so that the structure of interest, which is whichever vessel that you're targeting, is in the center of the image in order to achieve your best spatial resolution. A couple of examples of this. Now, there's 3 images here, right? So the image on the left is too shallow. And in this case, you won't really be able to see, sometimes you won't even be able to see the underlying, any of the underlying structures, right? So if you don't have this lateral orientation of your carotid versus your IJ, and the carotid is actually deep, you're not going to be able to see that. You're not going to know if you're getting too close to that with your needle tip. You're also not going to be able to see whether your needle is going through and through, right? Because if your needle tip went through, then that is going to be off your image. Now, on the other hand, this structure over here, this is too deep, right? You need to decrease, and you can see way past the vessel. So you will see if you went deeper with your needle tip. However, it really doesn't give very good resolution of what you really want to see, which is your entry path, right? So the more superficial structures closer to the probe, as well as your vessel itself. So you really want it to adjust it so that you can just see past the far end of the vessel and maybe, you know, half a centimeter deep, as long as you are including your artery for IJ access. In terms of other things for image optimization, so an appropriate degree of gain is really critical to be able to recognize your needle tip during dynamic guidance. So if you're under gain, right? So here you can see everything's just kind of black, right? Because you're under gain. So what's vessel, what's not? Is it soft tissue, is it not? And so once you increase the gain to an appropriate gain, then you can see everything overlying this, and this is the same image, just different gains. You can see that everything overlying is actually soft tissue, right? And this is your carotid artery over here. And then if you overgain, well, this is also a problem because this looks like almost a complete whiteout. So if your needle tip is coming in, what is tissue? What's the needle? You're not going to be able to appropriately differentiate it. So you really want a image where your vessel of interest is very hypoechoic, and then the structures around are slightly hyperechoic. Okay, so let's talk about vascular access now. So proper positioning is the key to success. And I think, you know, for doing our right IJ or, you know, left IJ or IJ positioning, that is, I think, has become pretty standard, where we want a patient to have their neck slightly rotated, to have the patient in a Trendelenburg position to really avoid the vessel collapsing. Positioning for, I think, some of our other structures is a little bit more variable. I know, for example, when cannulating the subclavian vein, I have some colleagues who will, you know, kind of pat it up to really extend the patient. I have one colleague who takes, you know, who wants to take the arm out because he finds it easier to scan. So it's just kind of whatever works for you, really, to get your optimal imaging. So prior to imaging, position your patient, and then prior to attempting vascular access, you really want to scan the vessel all along its course to not only identify an appropriate site of entry, but you also want to ensure the patency, make sure there's no clots, make sure it doesn't, you know, for example, for the IJ, you want to make sure that the vessel is highly patent, it doesn't, you know, kind of stenose as you go further down or further proximal. And you also want to make sure that you know what the baseline is for the patient, right? So you know what it's supposed to look like, and you want to make sure that's still what it looks like afterwards. Dynamic ultrasound guidance can be accomplished by either out-of-plane technique or in-plane technique, and that's what we're going to go over next. So in the out-of-plane technique, you're imaging the vessel in short access. The needle is going to enter the skin perpendicular to the probe, and only the tip of your needle is going to be visualized during the cannulation process. And this is really the preferred technique for most of our vascular access procedures, especially in the perioperative setting. So let me see if this will, let me see if this will play. I'm not sure why that just happened. Oh gosh, I'm so sorry. I think this is, for some reason, a linked video. Oh, here we go. And hmm, I don't think that that video is unfortunately going to load. Um, But basically, what I was trying to show with the video is, and I'm so sorry that's not loading, but basically what I wanted to show with the video is a technique that we usually use and I can send these out to you guys afterwards, but it's the technique that we use to do our out of plane dynamic ultrasound guidance. So essentially what you're trying to do is once you get the vessel in short access, you want to be moving your probe and your needle tip sequentially. So you're always basically, as soon as you get into the skin with the needle tip, you are trying to identify where the needle tip is in relation to the vessel. And this is obviously before you actually cannulate. And then you're moving. So if you guys can see my hand here, basically you're moving the probe, then moving your needle tip, moving your probe, moving your needle tip, and essentially what you're trying to do is you're always trying to keep your needle tip in view until it hits the vessel. And you can even image the needle tip in the vessel for a length of time before you actually thread your catheter. And I think this is a really, really elegant technique, which our residents learn very early on in their training, and it's actually become their preferred technique, for example, for arterial cannulation, especially of the radial artery. And it's this technique that actually I didn't learn until fellowship when I watched one of my residents use that to cannulate a pretty deep vein in the forearm. So I think it's very, very helpful both for arterial cannulation, for venous cannulation, especially if you have a patient who you're doing difficult IV on, and then can be also useful for your IJ cannulations as well to follow your needle tip into the vessel. Let's talk a little bit about both IJ and subclavian venous cannulation. So just the anatomy of the internal jugular vein, you have the IJ, which is right next to the internal carotid. And by anatomical landmark, you would look for the triangle created by the two heads of the sternocleidomastoid, the clavicle, and then insert the needle at the top of the triangle and aim for the ipsilateral nipple. By ultrasound, I think that this is something that I think has had very good evidence for benefit, right? For using ultrasound for internal jugular vein cannulation. In 2015, there was this Cochrane review, so a meta-analysis of data, which showed the benefit of using 2D ultrasound techniques in terms of decreasing complication rates, increasing the overall success rate, decreasing the number of attempts made, increasing first attempt success and really decreasing the time to successful cannulation, as well as decreasing the severity of accidental puncture of adjacent structures. And the thing that I thought was interesting in this review was that they showed that these benefits were consistent across both inexperienced and experienced operators. So it really kind of levels the playing field. Now, I think in the United States, real-time ultrasound guidance for IJ central venous catheter replacement is really kind of becoming the standard of care. The ASA guidelines in 2020s basically recommended using real-time ultrasound guidance for vessel localization and venipuncture for the IJ, and then when feasible, they said you can use it for the subclavian or the femoral vein. Of note, real-time ultrasound guidance is also recommended by the American College of Surgeons. There's nothing on a national level yet in the US. However, in England, the National Institute of Clinical Excellence had a guideline that was published in 2002, which also made the recommendation. Sorry. So in terms of internal jugular vein cannulation, you can have a number of different conformations here, but this can also be helped by turning the neck. Sometimes if you turn the neck, you can transform something like this into something, or something like this into something like this. Ideally, you get enough separation between your carotid artery and your internal jugular to kind of decrease the risk of inadvertent puncture of the carotid artery. But I think one of the things that I like to do is I like to usually enter the skin a little bit medial and then aim lateral. You never want to be aiming medial towards the carotid artery, right? So, and I see that a lot of times in our trainees where they'll just pick a site and then work with it, even if the direction of the needle is then pointed towards the artery, and that requires some correction. And again, you always want to be visualizing your needle tip and making sure that you're not, to the extent possible, not going through and through or towards something that you don't want to hit, although this can be a little bit more difficult in patients who are obese. So in terms of subclavian vein cannulation, just to review the anatomy, you have the axillary vein, axillary artery, which drains the upper extremity. And then this becomes a subclavian vein as it passes the lateral edge of the first rib posterior to the clavicle. And this artery the vein is usually located anterior and inferior to the subclavian artery. Now, overall, the evidence of benefit for ultrasound guidance is slightly less strong compared to the evidence for ultrasound-guided IJ cannulation. The more recent evidence, here we have a Cochrane review again, meta-analysis of data, and it did show that there is decreased risk of arterial puncture and hematoma formation, but there was no significant differences in other outcomes. For example, the incidence of puncture of the lung, right? So pneumothorax, as well as the success rate. Now, a more recent clinical trial from Italy did show a significant reduction in first attempt success as well as the mean number of attempts. But that group I think that group performed an in-plane approach. I think generally speaking, there just isn't as much standardization of how we do the cannulation and ultrasound-guided cannulation for the subclavian vein. So some people like to use the out-of-plane approach, and I think the nice thing about the out-of-plane approach is that you can both see the artery and the vein in short axis, and if you can visualize your needle tip, then you know that you're not going towards the artery. Here you can see this is labeled subclavian, but it's probably closer to axillary, or at least it would be very distal subclavian. But if you scan from going from distal to proximal, you'll see the pectoralis muscle on top and the venous and arterial structures on the bottom. And if you're out here, you should usually be able to see the pleura as well as the lung sliding underneath. As you scan more proximally, the head of the clavicle should come into view, and then this is pretty much where you would want to do your cannulation if possible. If you're using a in-plane technique, you would be imaging the vessel in long axis. Oftentimes what you're doing is you're identifying the target structure in the short axis, getting it right in the middle of your image, and then rotating the probe 90 degrees. Again, in these situations, you would want the end of the probe to face you, right? So you want the end of your probe or the left side of your screen to be facing you. And then you would want the needle to enter parallel to the probe. You want to be able to visualize the entire shaft of the needle. So this was, again, my attempt to try to show a video of this technique, but unfortunately, I think we'll have to skip that today. So again, here, your needle is going to appear, if you're looking at the subclavian vein in plane, then you're going to see your needle coming in from the left side of the screen. And here you can see, this is your proximal axillary, this is your distal subclavian, kind of like the head of the clavicle. And then your lung pleura is underneath here. And then your needle tip would enter this way, and you should be able to see the entire shaft of your needle if you're doing this appropriately.
Dr. Lee,
post-cannulation. Oh, sorry. Okay. I think I should be almost done, but I will go ahead and get through the last couple of slides. For the post-cannulation assessment, for venous cannulation, you should always be looking at the position of your guide wire and making sure that's where it needs to be on your ultrasound image. And then following a successful vascular cannulation, or I guess even an unsuccessful attempt, you can use your ultrasound then to look for complications such as hematoma, which is the most common thing I see, or pneumothorax, which is something that Dr. Nikrabon talked about in her previous lecture. And hopefully this one will actually play because it's not a YouTube video, but this is just an image of us looking for a wire on ultrasound. And this, you can see this in the IJ. This is the carotid artery. And we're actually following this and angling under the clavicle so that we can see the wire as it dives down to meet the subclavian. And obviously, this is not the only method you can use to make sure that you're in the appropriate position, right? You can use transduction. You can use, if you have a TE probe in, which is what I actually like to do in our cardiac cases, to look for the wire in your left atrium. But I think that's a little bit beyond the scope of this lecture. Okay, so I think that's all I have. So I'm happy to take some questions at the end. And just in summary, our real-time ultrasound guidance is used during vascular access procedures to decrease the rate of procedural complications. In most cases, you should be using the high-frequency linear transducer for optimal spatial resolution. And 2D imaging is really the modality of choice during dynamic ultrasound guidance, although color Doppler can be useful during the pre-procedure scanning to identify the structure of interest. Other things to mention, you need to make sure that you are choosing the appropriate probe and the appropriate orientation to maximize your chances of successful cannulation. You want to optimize your image by adjusting your laterality, depth, and gain prior to actually needling the patient. And then you can do this either with out-of-plane or in-plane technique. And most of us, I think, prefer the out-of-plane technique in these situations. Following successful needle entry, the ultrasound imaging should also be used to confirm guide wire placement, as well as to rule out complications such as hematoma or pneumothorax. And that's all I have. Sorry, I hope I haven't gone too far over time. I saw some of the messages from Robin, but I'm happy to take any questions that you guys might have. Oh, thank you, Sarah, for sending the videos.
My pleasure.
You can stop sharing screen so we can see people.
Okay, sounds good.
So does anyone in the group have any questions for Dr. Liu? Any or want to share any kind of issues you've had with trying to obtain vascular access with ultrasound? Because we could always provide some troubleshooting techniques.
No, Sarah, I was actually wondering, how do you like to do your subclavian vein ultrasounds? Because I actually, in my practice, because I'm not an ICU physician, I don't cannulate the subclavian vein nearly as often as I would imagine you do.
Yeah, so that's a really good question. Of course, the first thing I like to do is to use, if I have it, a small footprint linear probe, because oftentimes when you're, and I'm going to put my screen down so you can see, but when you're going for the subclavian, you have to go quite lateral with ultrasound in order to see the vessel. Sometimes it almost feels like you're getting close to the shoulder of the patient. So I use a smaller footprint linear probe if I have it. And then I usually do an out of plane technique. And the reason why I do out of plane is because it's crucial that you're able to see both the subclavian vein and the artery next to each other so that you don't inadvertently think you're looking at the vein, but you're actually looking at the artery. So I keep them.
Oh, sorry
go
to
ahead.
interrupt, Dr. Nikrabon. I just had a couple. I thought you were at an ending spot, and there were a couple of questions.
Oh yeah. So I just was gonna say, when you go on in the out of plane technique, you're gonna then go use your needle, go in the middle of your probe, aim towards the subclavian vein. And what's really disconcerting for those of us who like spent our careers doing this without ultrasound guidance is you're like this with your needle.
Yes.
And when someone walks in the door, they're like, "What are you doing?"
Yeah.
So you have to be really, you have to make sure you can see the pleura, but yeah, you're going to be pretty steep with your needle angle aimed toward the target. So that's usually how I go about doing it. Sometimes it helps because you're so close to that shoulder to like put a roll behind the patient's back so that the shoulders fall back and kind of out of the way. Sorry,
Yeah,
Robin. Go
I
ahead.
agree.
Oh,
I totally
fine.
agree, Sarah, with the steepness of the angle. I learned landmark technique when I was a trainee, and we were always taught to really keep the needle as parallel as possible and really not aiming down towards the lung. So it's very disconcerting, like you said, that you're like basically aiming your needle straight, like where you think the
Into
lung
the
would
chest.
be. Yeah, exactly. And I think that was actually part of the reason too that the incidence of pneumothorax was maybe not different in many of these studies between ultrasound guided versus landmark technique. But again, it does decrease the incidence of other complications. Sorry, I see some.
There's some questions. Yes.
Questions. Mm-hmm.
What's your opinion on oblique access for vascular cannulation? For subclavian, what do you prefer, in plane or out of plane technique? And do you teach landmark technique as well in case US ultrasound doesn't work, or does it always work?
I think those are great questions. I think we'll start with the first one. I have to say, I guess, could you clarify what oblique access refers to? I think I'm a little confused about that, unless Sarah, you have a answer.
Well, sorry, go ahead.
Yeah, was the question to me? I had posted this question.
Yes, that's correct.
Hi, I'm Vibha. Yeah, hi. So, hi, I'm Vibha. And by oblique axis, I meant that the probe is placed over the vessel in out of plane technique, but the needle puncture is done in plane technique. So I read about this in some of the articles, and it said that it has advantages over both the short axis and the long axis, like it takes care of the disadvantages of both. So I was wondering, what is the practice in your setups?
Yeah, I've never done the oblique technique. This is actually the first time I'm personally hearing of it. And I can see what you mean, because then you can see the vessel both in short axis. So you know that you're not hitting the artery, but then you're actually, coming in. I think that would be especially with the IJ, I think that would be a little bit, I would imagine that could make it a little bit difficult to thread the catheter and thread the wire, but again, I have to say I don't have any real facility with it. So I would say I do not use the technique, but and it's not necessarily a technique that I would recommend or that I teach to trainees. But that is an interesting point, that it could solve the problem of visualizing the entire needle shaft. Now, I do think that the technique that we use here to visualize our needle tip, I think it works really, really well, because even though you're not able to visualize your entire shaft, if you're always visualizing the tip, you know where that is. It's not going to go somewhere that you don't want it to go.
And to Dr. Liu's point,
thank you.
We call that, Vibha, the technique we use, we call it the inchworm technique in a way. Because if you can see my hand, if your probe is like this and you're going out of plane, when you go in with your needle, every time your needle advances, your probe advances. So you're following the needle tip, and then it advances and your probe advances, and then it advances and your probe advances, so that you can always see where the needle tip is and you don't lose it. Because if you keep your probe in one spot and you go here, then suddenly the needle tip is all the way on the other side, and you're just seeing the shaft and have no kind of good spatial awareness of where the needle tip is. So that's a really nice way to be able to keep it out of plane and follow the needle tip.
Thank you.
Okay. And I think we sort of answered the subclavian vein. Would you prefer in plane or out of plane technique? I also prefer pretty much out of plane for everything. Mostly, I had just an anecdote. I had a co-fellow who trained at Virginia Mason, which is where Stargate came to us from. But they do a lot of regional, and I think those residents get very facile with doing in-plane technique. And I remember, like at the beginning of the year, she kept trying to do in-plane technique for her IJ cannulation and got shot down by like every single attending. But for me, I prefer the in-plane just because of my own facility with it. Now, again, I think with subclavian vein, there isn't as much standardization of practice per se currently, but I've seen studies that did either. And Sarah, it sounds like you do out of plane as well. Yeah. Do you teach landmark technique? Oh, yeah, sorry. Mm-hmm.
Oh, I was just going to say, I do both things. And what I have found, well, not for the subclavian, as you know, but what I have found is that when the structure is very superficial, or when things are going to be a bit more challenging and I really need to see the trajectory of my needle, that's when I go in plane. So if my landmark is very superficial, I can go in plane there for the IJ if I have enough room in the neck, because that the whole time I can keep my needle shallow and watch a trajectory of my needle. So that's kind of one of the few times that I'll go in plane for vascular access.
I personally probably again, I think just whatever your comfort level is, and for me, my comfort level is really with the out of plane technique. But I think either can be useful depending on the situation for sure. Do you teach landmark technique as well in case ultrasound doesn't work, or it always works? Well, I mean, I wouldn't say it always works, but that's a good question. So I learned both, and I think that there's a lot of preference for ultrasound now today, and especially in US institutions. And I think it is a safer way to go. I don't think we teach landmark technique routinely to our trainees, and I have to say I have kind of mixed feelings on it, because on the one hand, I don't want it to be a lost art, because it is a lost, an art in a way. And it's helpful when you don't have the benefit of ultrasound, right? Like your machine breaks, or every machine is being used and you don't have something available to you in an emergency situation. I think you should be able to do it with a landmark technique, but it's not something that we start our trainees on anymore. And I would say that one of the things that I've personally had a lot of like misgivings about is the way that, for example, I think I mentioned earlier that our even for arterial access, right? So radial arterial lines, most of our trainees will jump directly to ultrasound for placement. And I think the rate at which they achieve success is very, very high. And they have a very elegant technique. But if you just give them the needle without an ultrasound, half the time it seems like they don't really know what they're doing. And so I think that there is room to learn both. And you should know how to use both techniques ideally. I hope that answers the question.
Yeah, so I just want to interject really quickly, just because we're just a little bit over time. We are recording this. If anybody wants to stay on, Dr. Nikravan, Dr. Liu, if you want to continue to answer the questions, we can, stay on for a little bit longer, and we will record the responses. So if anybody wants to, is short on time and needs to leave, we'll definitely be sharing the recording later.
Thank you, Robin.
Yeah.
And I saw there was a follow-up question that says, is it always available? I'm assuming you're referring to ultrasound machines. I think pretty much here it's always available. We have a plethora of ultrasound machines, which actually wasn't even the case when I was in training as a resident. Okay, in out-of-plane technique, as you said, if I move the probe along with the needle tip, if deficit insertion increases over the course, how can I see the needle tip correctly? Yeah, so I think that, that it's, again, trying to get the facility with it. As your depth increases, you may have to make very small, much smaller movements as you go forward, right? Because like the amount that you move your tip in is going to, it's not going to increase this as much, right? The kind of the forward motion as much as it is going to increase the depth. So in that situation, instead of going, like let's say you're going really shallow, right? You move your probe, move your tip, and you should still be in view. If you're going really deep, if you move your probe too far, you're probably going to lose it. So you kind of make smaller. For me, I'd like to just make smaller inching movements. So that's, but you should still be able to see your needle tip unless it's just a super, super deep structure, right? In which case, like maybe your probe isn't the right probe. Like for example, if you have a really deep femoral access. Do you take chest x-ray after ultrasound guided central? Not in the OR, no. But once they get upstairs, so we basically kind of confirm the wire placement. We make sure that we can draw back on all the lumens to make sure that we're in the right space, right? And then we just use it. But in the ICU, for example, after you place a central line, the standard here is to take a chest x-ray, make sure that it's appropriate, like, in appropriate position on the chest x-ray, and then the order to use it is entered. So, and then after we place it in the OR, once they get upstairs, the chest x-ray is also taken.
And if I can just interject real quick here, there are, and this is what the beauty of ultrasound is, there are other ways with ultrasound that you can kind of confirm that A, you're in the right place and the common bad things have not happened. So when the line is going in with the wire, there have been studies, and we've done it too in real time, where you can do a subcostal 4-chamber view of the heart, which in the next series that we have in April, where Dr. Nibras Bugrara is going to be here from Albany Medical, and he has basically, been studying just doing one view for cardiac ultrasound as an entry point into ultrasound, and that's the subcostal view. And you can look in that subcostal view and see your wire in the right atrium, so you're in the right place. So that's one way. The other, like Dr. Liu said, is you can follow the wire down into the innominate for when you're in the IJ to make sure that you're actually in the right place and you haven't gone into the vein and then through it and into the artery. And the last thing is when it's all said and done, you can also look with the ultrasound and the lungs in the anterior regions of the lungs and make sure you see lung sliding on both sides of the chest, or on the side where you place the central line, to avoid, so that there's not a pneumothorax basically there. So if you can't get a chest x-ray, then this is kind of the beauty of ultrasound. We can use it in a multimodal fashion. Sorry to interject.
No, that's great. Thank you. The last question, any tips for femoral vein cannulation? I have to say, I also don't cannulate the femoral vein quite as much as I cannulate the IJ. I definitely use ultrasound to cannulate it, as opposed to, I think, I've seen, in emergency situations, obviously, you may not have the benefit of ultrasound. You just have to feel for the pulse and go for it. But I also still like to use, as long as the patient is, if the patient is a normal size, and I think that the vessels are pretty easily visible, I can still use the linear probe. But in more obese patients, obviously the linear probe might not capture the vessel because of the depth of the vessel. I also still use the out of plane technique when I do my femoral venous cannulation. And I think the main issue is that, sometimes, again, especially if you're using a curvilinear probe, visualizing your needle tip can become a little bit more difficult. And you sometimes may end up just having to kind of try to figure out, what is the trajectory of my needle instead of actually visualizing the needle tip. So it can be a little bit more challenging. Sarah, any thoughts?
Yeah, I think as a critical care doc, we definitely probably do femoral lines a little more frequently in kind of that emergent setting you were talking about, Dr. Liu. And, a couple of, I think, important tips. One is the more proximal you go, the closer you are to the inguinal crease, the more round and kind of clear the femoral vein becomes, but you have to be really cautious not to be in the inguinal crease because you don't want to basically get into the patient's abdomen or pelvis. So that's number one. So I usually go up to the inguinal crease and then I eke down away from it, still visualizing the vein and getting it kind of nice and big and round in the center of my screen. I also do it out of plane, like Dr. Liu had mentioned, so that I can keep the artery and the vein kind of in my sight. And then the next thing I would suggest is because, and I'm going to do it this way, because the femoral structures are deeper in the body, oftentimes it helps to understand how far you are from them. Like, so you can look on the side of the ultrasound machine, and usually on vascular imaging, each of the hash marks is half of a centimeter. You can go through it and count it and make sure that your machine is like ours are. And if you can see, oh, it takes me 2 centimeters to get to the top of this needle, then I'll typically go away from my probe about 2 centimeters, maybe 1.5. And the reason why is because I kind of want to keep a shallower angle for the femoral. Because if you go like this with the femoral wire, then you're basically going to be going through all this tissue and trying to dilate it and put your catheter in. And what ends up happening is oftentimes with a bigger catheter. So let's say you needed to put a cordis or some bigger catheter, you end up bending the wire because you're trying to do this and your wire's like this. So if you have about 2 centimeters, go about that distance, maybe a little bit less away from the probe, so that by the time you're close to the top of that needle, your needle tip and your ultrasound probe are on top of each other. And then that way, when you put your wire in, it's not at such a steep angle, you can dilate it and then put your catheter in on top. So those are kind of the techniques that I've learned over time, because I've been burned several times by kinking my wire from, keeping that steep angle.
Sarah, I think Dr. Nebron, I'm going to have to jump off because I have to start a case in 15 minutes.
Yes, thank you so much, Dr. Liu. We're so grateful to you.
Thank you so much.
And I think there's just,
no worries. I think there was just one more question. If you do have time to answer it for him, but for them, but I'm going to go ahead and jump off, and thank you very much, everyone, for your attention. And again, Dr. Nebron, I really appreciate the opportunity to present on this topic.
It was my pleasure. Thank you so much for your time. I'll be happy to answer this last question. Is there a role for right atrial swirl test for correct central cannulation confirmation? Absolutely, absolutely. If you can see, you can take the blood you get back from your central line, and you can kind of, we call agitate it if you want, but what you can do is you can take a little bit of blood back into a syringe, take another syringe with saline, put a stopcock between the two, and basically agitate them. So you put the blood into the syringe with the saline, and then the saline with the blood back into the other syringe, just to create some micro bubbles from kind of agitating those syringes. Then you take that syringe with the blood and the saline in it and hook it up to your central line and push it in, and look in your subcostal view to see if you see a rush of bubbles in the right atrium. And that's kind of what we do when we're testing for PFOs or some sort of, intracardiac shunt. We'll do that as well, but that's a great way of being able to see that indeed what you're giving will go into the right atrium. So thank you all so much for your time. We really appreciate it. We're so excited to see you come back next time in April. Dr. Brugrara is really amazing. He is a national expert in this topic of how to teach us how to do cardiac ultrasound very easily. So an easy entry point into cardiac ultrasound with one view. I highly recommend attending it. He gives talks across the country, across the world. Is a good friend of mine, which is, I think, the only reason we were able to get him to come and talk to us. So really, I would recommend coming in April to see him speak. He's an amazing speaker. I hope you all have a great day and thank you again for your time.